Hi, good afternoon. Thank you for the invitation to speak today. I've given my fair share of talks over the years, but I must say I've never followed anything like that, so I have a lot to live up to here, pressure. And thank you for being here. I know it's late in the day, and I do apologize. I have a lot of information here, and I'll try to get through it as quickly as I can. But in terms of objectives today, just a brief overview of melanoma and specifically to review therapeutic advances, both in molecular target agents as well as immunotherapy, really highlighting and focusing mainly on practice-changing clinical trials over the years and most recently, and then discuss the impact this has made on survival for patients with advanced melanoma. So melanoma, of course, is derived from melanocytes, and melanocytes originate from the neural crest during embryogenesis, and they migrate to the skin, the eyes, and the mucosal membrane. So these cells, being neural crest-derived cells, really they were built to last. They don't easily die off. They're predominantly located in the basal layer of the epidermis, and they're responsible for melanin production. And this gives skin its color, and the function of melanin is to absorb UV radiation. And melanoma can come from any of those sites these melanocytes migrate to, but the predominant site of melanoma is the skin, but it can occur in the ocular area as well as mucosal melanoma. And so melanin production, really our skin color is based on the ratio of what's called eumelanin to pheomelanin, and it's polymorphisms in the melanocortin-1 gene that are associated with differences in the type of melanin produced. So eumelanin, which is dark, very photoprotective, is produced when melanocytes are stimulated through the melanocortin-1 receptor signaling pathway, and pheomelanin, which is lighter in color, often has a red tinge, is made when melanocortin-1 is inactive. And it's this ratio of eumelanin to pheomelanin that gives us our skin phenotype. And so patients on the left-hand side here are predominantly pheomelanin, poor UV-protected phenotype, and eumelanin, a darker, more protective phenotype. And out at the pool, there's a lot of people with that pheomelanin phenotype baking in the sun, which is kind of scary to look at sometimes. But it's this UV radiation and lack of photoprotection when there's a predominance of pheomelanin that leads to high tumor mutation burden in cutaneous malignancies. And this is a study published a couple of years ago that basically just took various tumor types and looked at the tumor mutation burden in those. And you can see on the right-hand side of this slide that it's cutaneous malignancies that lead the way. So basal cell carcinoma, cutaneous squamous cell carcinoma, and melanoma tend to have the highest tumor mutation burdens in cancer. And whether it's this relatively high mutational burden that makes cutaneous malignancy specifically sensitive to immunotherapy and relatively resistant to long-term targeted inhibition, it's hypothesized, but not entirely clear. And so melanoma continues to be a major global cancer burden. The highest incidence and mortality is concentrated in North America, Western Europe, and Australia. And if the current rate continues, it's estimated by 2040 there'll be over 500,000 new cases of melanoma and 96,000 deaths. And I like to put this slide up. This is an old slide, but this is where we came from. So this was published in 1995 that looked at various therapeutic trials and survival for melanoma. And you can see that from the 1970s into the 1990s, there really wasn't a change in mortality for patients with metastatic melanoma, with median survival of around 7 to 8 months. And then when we reached 2011, we started to have rapid approval of drug after drug after drug that had positive clinical trials. So in the 1970s, we had dacarbazine, which we would give because there wasn't anything else to do. In the mid-1990s, interleukin and interferon, and then again beginning in 2011, both targeted therapy and immunotherapy. But the problem with these rapid approvals is we didn't know which is the best way to sequence them, who should get targeted therapy, who should get immunotherapy, were these responses going to be durable? And now we're starting to get some long-term follow-up that answers a lot of these questions. And this is the trial that really, in my opinion, kind of set the standard of care really to this day for melanoma, the so-called Checkmate 067 study, initially published in 2015. And here's the design of that study. It was 1-to-1-to-1 randomization of patients receiving ipilimumab, nivolumab combination versus nivolumab single agent versus ipilimumab single agent. Now, what's important about this study is that it was not powered to detect a difference between ipi-nivo and nivo monotherapy. The arms were designed to have differences between ipi-nivo and ipi and nivo and ipi, but not ipi-nivo and nivo. And so interpreting these data, it is complicated somewhat by that fact. But this was the initial publication back in 2015, response rates to combination immunotherapy over 50%, response rates to single-agent PD-1 over 40%, and you can see that the progression-free survival curves there were favoring the PD-1 arms, but follow-up was short. Those curves were unstable, and we started to get long-term follow-up of this, and this was the 5-year follow-up published back in 2019. And if you look at overall survival, 52% overall survival at 60 months for the ipi-nivo arm compared to 44% for nivo and 26% for single-agent ipilimumab. So this is really what would set the standard of care for immunotherapy. And then what was published, or what was presented at ASCO earlier this year, was the 7.5-year follow-up of this study. So now we're really getting long-term follow-up data. And I will say, and I apologize, this slide is incorrect, this is the 7.5-year overall survival, not melanoma-specific survival. This is overall survival. But you can see now we have a median survival for ipi-nivo of 72 months in this study, and this compares to 8 to 9 months, or 7 to 8 months in that previous study that we looked at. So half of the patients alive at 72 months. And this is the melanoma-specific survival here. So at 90 months of 55% melanoma-specific survival for those who received ipi-nivo. And so, again, long-term follow-up showing that these immunologic responses can be durable. And what's also interesting that have been presented here is that this is a table, these pie charts, that look at patients who are just alive and followed on study. And so if you look at the patients who were alive, followed on study, who received ipi-nivo, there's 138 patients. 4% of those patients were still on study therapy. 19% received subsequent systemic therapy, but 77% of the patients were treatment-free and never received a subsequent therapy. So if we can get the immune system to recognize this tumor, it tended to be durable, and often these patients can come off treatment and remain treatment-free for years and years. But starting in 2011, we also had the targeted therapies approved. So, how do these play a role in what we choose as first-line therapy for melanoma? Well, this is the phase 1 study of vemurafenib, a BRAF inhibitor that was published in New England Journal of Medicine now 12 years ago. And as you all know about targeted therapy for melanoma, the responses can be quite dramatic. And this was a baseline PET scan for this patient. You can see widespread metastatic disease, and then a day 15 follow-up scan with marked improvement. So these responses could be very deep, and they could be very rapid. And it wasn't just a single patient that received it. This is the waterfall plot, and the majority of patients who were on the therapy had decrease in their overall tumor burden. So these can be very active agents, and it quickly became clear that it was combination targeted therapy that was better than monotherapy, so BRAF-MET combination. And this is the historical data sets of vemurafenib, cobimetinib versus vemurafenib alone. And this is dabrafenib, trametinib versus vemurafenib. So dual targeted therapy is superior. But the problem with this was that the median progression-free survival, even with combination targeted therapy, was still only about 12 months. And the follow-up, similar to that initial Checkmate 067, was short. So how would these things play out in long term? And now we're starting to get long-term data for targeted therapy as well. And this was published a couple of years ago in the New England Journal of Medicine that looked at 5-year outcomes. And in the sake of time, we'll just look at that bottom right-hand side, which is overall survival for patients who had a normal LDH and limited disease, so less than 3 sites of metastasis. And you can see their 5-year survival was over 50%. So even though progression-free survival tends to be rather short with targeted therapy, and that's always the knock on it, there is a subset of patients that can do well for extended periods of time, and those tend to be patients with low disease burden overall. So the question is, how do we sequence these therapies? Which should a patient get first? And we didn't know the answer to that, really. We all had our biases, and our biases was towards immunotherapy. But thanks to Mike Atkins and his colleagues, there was a presentation at ASCO in a plenary session earlier this year that really sought to answer that, and it's the so-called DREAMseq study. And it was a randomized trial that took patients with BRAF-mutated melanoma and then randomly assigned them to receive ipi/nivo up front. And if they progressed, they then received targeted therapy with dabrafenib/trametinib. Or they were randomized to receive dabrafenib/trametinib as the first-line therapy, and if they progressed, they then received ipi/nivo. And the results of the study are quite striking. So in terms of progression-free survival, favors immunotherapy. With a median progression-free survival of about 12 months with combination immunotherapy as the frontline versus 8.8 months. The duration of response is much improved with immunotherapy over targeted therapy. So if you could get patients to respond to immunotherapy, the chances it was going to be durable was relatively good. And then overall survival was improved for those who received immunotherapy up front. And at the initial presentation, the 2-year overall survival for immunotherapy was 72%, compared to 52% for those who received targeted therapy up front, with an absolute difference of 20% in 2-year overall survival. These data were updated at ASCO this year with a 3-year overall survival rate of 66% for immunotherapy as the frontline treatment versus 43% for targeted therapy. So this really set that immunotherapy should be the preferred frontline option, even in patients with BRAF-mutated melanoma. But you can see if you look at the curves early on, actually targeted therapy does a little bit better than immunotherapy. And you can see those curves then cross at about 10 months. And so there are patients on immunotherapy that can have early deaths. And this looked at those 24 patients on this study where their median survival was only 3 months. They tended to have a higher disease burden, tended to be elevated LDH, stage M1C. Their median treatment duration was about 6 weeks. And various reasons they came off study, but basically none of those patients were able to cross over to targeted therapy. So there is a group of patients that still does poorly. But if you look at overall survival rate per subgroup analysis, it all favored immunotherapy as a frontline agent over targeted therapy, and that included whether they had V600E mutations in BRAF or V600K. It included whether they had favorable prognostic factors or not, which is the best group for BRAF inhibitor therapy. All favored immunotherapy as the frontline agent. And these are interesting data here from this study that looks at overall response rate by treatment arm. And for arm A, which is ipi/nivo up front, 46% response rate. For arm B, targeted therapy up front, 43% response rate, pretty similar. For arm C, which is patients who crossed over from immunotherapy to targeted therapy, a 48% response rate. But for arm D, those who crossed over from targeted therapy to immunotherapy, only a 30% response rate. And if you look at progression-free survival, it's quite striking. So arm A, arm B, 11.8, 8.8 months progression-free survival, as we talked about. But for arm C, those who went from immunotherapy to targeted therapy, a progression-free survival of about 10 months. But for those who started with targeted therapy and then received immunotherapy, only a 2.9-month median progression-free survival. So it's interesting that patients who start with targeted therapy and you try to salvage them with immunotherapy, you're often not able to do that. And so really, in terms of summary, that ipi/nivo followed by dabrafenib and trametinib, if needed, is associated with improved overall survival at 2 and 3 years. And this really sets the standard of care. Crossover was frequently not feasible, in many cases due to CNS progression, so there is a group of patients that still does poorly regardless. And what also is new is that we have a new combination of immunotherapy for patients with metastatic melanoma, and this is relatlimab and nivolumab. Relatlimab is a checkpoint inhibitor to LAG-3, and so this is and LAG-3 is another immune checkpoint, inhibits activation of the host cell, produces a more suppressive immune response, reducing cytokine and granzyme production, decreased proliferation, and encourages differentiation of T regulatory cells. This was a rather large study randomizing patients to nivo-rela versus nivo alone, with the primary endpoint progression-free survival, secondary endpoint overall response rate, and overall survival. And at the initial publication in the New England Journal of Medicine, the median follow-up was 13.2 months, and they presented that progression-free survival was superior to nivo-rela, and that led to approval in the United States. Updated at ASCO this year was an additional 6 months of follow-up where they updated the progression-free survival and then reported on the secondary endpoints of overall survival and response rates. And here's the progression-free survival curves, median progression-free survival over 10 months for nivo LAG-3 versus 4.6 for single-agent nivo, a hazard ratio of 0.78, so maintained statistical significance. But in terms of overall survival, median overall survival not reached for the combination immunotherapy, 34 months for single-agent nivo, hazard ratio of 0.8, but it crossed 1, so it was not statistically significant. A lot of the patients did go on to receive subsequent therapies, including ipi-nivo or BRAF/MEK inhibitor, and certainly these effective therapies complicate improving overall survival benefits for some of these newer agents. And both progression-free survival and overall survival was favored across subgroups. As was pointed out earlier, one subgroup in terms of progression-free survival, if PD-L1 expression greater than 1%, is really kind of approaching 1, but all subgroups favored the combination immunotherapy. And in terms of response rate, about a 10% difference in overall response rate, 43% for combination immunotherapy versus 32% for single-agent nivo. Combination immunotherapy is more toxic, and if you look at treatment-related adverse events, about 21% for the combination immunotherapy versus about 11% for single-agent nivo. So as you add agents, it certainly becomes more toxic, and that's true with ipi-nivo. That is probably the most toxic combination immunotherapy regimen. Probably nivo-rela falls in the middle of that compared to single-agent PD-1. And so the summary of this relatively 047 study, it met its primary endpoint and that it continued to demonstrate a progression-free survival benefit with longer follow-up. They stay here at a clinically meaningful improvement in overall survival, but it did not meet statistical significance. There was an increased response rate, and the toxicity profile is manageable, but it is more toxic than single-agent nivo. So is that it? No, there's more, and a lot of people don't even know this is my cousin Vinny, which kind of puts my age there, which is a little scary. But in terms of other things which we didn't have time to talk about, certainly adjuvant therapy for stage 3 melanoma has been approved for a number of years now, but what was also approved in 2020 is we now have adjuvant PD-1 therapy, pembrolizumab, for high-risk resected stage 2 melanoma. So these are localized melanomas, just deep primaries, and there was a study that showed those who received pembrolizumab versus placebo had improved outcomes. And for the first time, we have a treatment that has shown an overall survival advantage for uveal melanoma, which is notoriously difficult to treat. And there's a drug called tebentafusp, which is a bispecific protein that links CD3 to the melanoma cells and has shown an overall survival benefit. So where has all this led? Well, it's led to improved survival. And this looks at age-adjusted mortality for patients with melanoma going back to 2001, which is the blue curves here for patients with distant disease, or the blue line here for patients with distant disease. And you can see it was flat, as we talked about. Nothing we did showed a difference. And then beginning about 2010, the mortality has improved steadily. And so despite the fact that melanoma is a tumor type that in both men and women is kind of leading the way in terms of new cases, increased incidence, it's the tumor type that has the best improvement in terms of mortality. And so what we talked about, there's the long-term follow-up of ipi/nivo, which demonstrates a melanoma-specific survival of over 50%. And then the DREAMseq study demonstrated that immunotherapy is the preferred frontline agent over targeted therapy in most situations, but there still is a population of patients that will do poorly no matter what they receive frontline. And now we also have the combination of nivo-relatlimab, which is a LAG-3 antibody, as a frontline option. And I'll stop there. Thank you very much.
Audience questions? I have a virtual question, which you may have gone a little bit over. How do you personally choose in your practice between pembrolizumab, ipi/nivo, and rela/nivo?
I think that if a patient is otherwise healthy enough to tolerate ipi/nivo, there's no contraindications. To me, that's the preferred frontline treatment. Now, nivo-rela has shown a statistical significant benefit in terms of progression-free survival to single-agent nivo, which actually ipi/nivo didn't. But we do have for ipi/nivo the long-term follow-up now, with over 50%, over 50% of the patients alive at the 7.5-year follow-up point. So I think that the high response rates and the long-term follow-up of the ipi/nivo really sets that as the standard. If patients aren't candidates for ipi/nivo, but they're relatively good performance status, then the nivo-rela would be preferred over single-agent PD-1 in our practice.
Okay, I have two more questions that popped up. This one's a lot of abbreviations. How to identify the few who do not fare well or drop out in the first 10 months while on immunotherapies? Will those do better if treated with dual target agents at first? Do those dual target agents penetrate through blood-brain barrier?
The answer is we don't know how best to treat those patients. Often what we have to do off of protocol is they do get targeted therapy because we're just trying to control their disease. What I'll often do off of protocol as well is add immunotherapy to the targeted therapy, and there is data to support that patients with melanoma that receive BRAF/MEK PD-L1, that is an approved combination, and you can improve duration of response. So that's a patient population that's very difficult to treat. Often what we'll end up doing is starting with a targeted therapy and then adding immunotherapy to just hope that we can maintain that response. And yes, targeted therapy does cross into the brain, and there's data that dabrafenib, trametinib has intracranial responses.
And why would you not study nivo-rela versus nivo-ipi?
I think that's a good study. I don't know if it's going to be done, but that's certainly something that's would be nice to have that data. Whether or not we'll get it anytime soon, I don't know.
Okay, and last question. What can we do to help patients with poor function and functional status?
Those are the difficult patients, and it's individualized. I mean, do they have enough time to try to get an immunologic response? Can you start with immunotherapy? That's always preferred if that's an option. If they're really, really sick, they don't have time to try immunotherapy, then we have to try targeted therapy in them to try to control disease, at least in the short term.